There you go.
All right, this is the question that we had last week. It deserves a lot of discussion because it's a very educational. And as I was putting this together, I hate to say that my wife, who is a conspiracy theorist, I have one of her slides here because I want to shed a little light on what's going on here. All right, I am the next door neighbor to a 50-year-old truck driver. So this is a young man. And he became confused while driving his 18-wheeler back to Georgia from California. I took him to the local hospital, and a head CT scan showed a big mass. The oncologist saw him the next morning and had an MRI and a brain biopsy done by a brain cancer surgeon. The surgeon told us he had a high-grade glioma and that the tumor was too big to remove and that it crossed the midline, and that the oncologist would direct our treatment, give us some chemo pills and radiation. Now, we have not discussed a brain tumor in quite some time, but that is the standard approach if you can't do an operation and debulk the tumor before you start chemo and radiation. Here's the question, actually. He has no family nearby, and I am confused about how to help him best. Your suggestions. I work full-time. I took off several days to drive him to the tests and biopsies, but I cannot take care of him full-time, and he lives alone. So what you really got here is you have a psychosocial support question that revolves around how complicated is a treatment going to be of a truck driver and what's that all about. So as I was discussing this with my nurse, which I do every week before I start talking about it, she came up with several interesting things, and I think I hope that this approach is educational to you. So put up this picture here. Now, here you got two really good colleagues. Who are those?
Ted Kennedy and John McCain.
Now, they're not in the same party, are they?
I don't know. I'd debate. You asked the question, and that's tough. They're not the same party.
Pull that down.
Just in the interest of moving along.
Pull that down.
With brain cancer, right?
Are they privileged and are they well connected?
Yes.
Okay, so what I mean,
they have the ability to get all the care. They had the ability to get all the care, all the support, everything necessary
that could possibly happen.
Right, those two. Yes.
Okay, so here are two different people with different backgrounds. One of them's been a prisoner of war for a long time, but neither of them have, as far as we know, had any exposure to any environmental thing that's likely to make them have a brain tumor.
Okay.
Both of them had high-grade tumors, which we'll talk about in a minute. Both of them got the top care available in the world, and both of them had the standard response. For 6, 8 to 12 months, they were functional. For the next 6, 8 to 12 months, they deteriorated, and within 24 months from diagnosis, they generally died. And in the last half a year, they couldn't brush their teeth or shine their shoes or dress themselves because they had begun to have deterioration in their total brain function. So that means that you have to have a support system. That's one of the questions here. So we don't. We'll come back to that again in a minute. Put up that next. There are conspiracy theorists, and you have some that come on your program. You got that picture right there? Who are blaming the supposed increased incidence of brain tumors, which there's not really much of an increase in brain tumors, on exposure to
5G, electricity. There's a lot of things. Cell phones, holding the cell phone. Right.
Now,
holding the cell phone.
Go back. Well, I'll show you this.
It hasn't been long ago that there was a lot of articles coming out that this caused tumors.
Okay, now what does this say? Changes in the glioma age standard incidence rate and location relative to 1995. What's significant about 1995?
So when we started getting cell phones.
So you got a lot of cell phones. Now, if you put that up and looked at it, you would think that there's a huge rise in brain tumors corresponding with the widespread distribution of telephones, right?
Right.
Put that down. That's not what that shows. What that actually shows is that the brain tumor incidence is more in the temporal lobe now than it was in other parts of the brain, which we're going to come to here in a minute, and that there may be some shift, although it's not clear. That was the conspiracy theory graph there, that the location within the brain may be somewhat different of tumors. Now, not the tumor that McCain and this man here have. You with me? I think you're with me. All right. So when you put up the next one. When you think about the brain, you're thinking about a single organ, aren't you?
Yes.
The brain. Well, if you look real carefully at this, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 14 different areas.
Regions of the brain.
Regions of the brain, all of which can have peculiar tumors of that region or cell type that are not related. So take that down.
Well, that's what I was going to ask you, because in the question, the doctor says it's too close. When you get around the spine and the brain and behind the ear, you got to be in areas where if you touch certain parts, you're going to lose your memory. If you touch certain parts, you may get paralyzed or whatever.
You're going to quit breathing.
Yeah, well, this has to be for a surgeon. I'm not saying removing cancer anywhere in the body is a simple process, whether it be with treatment or whatever. But when you get around the brain and the spine, that has to be...
Well, yeah, you're in serious territory there.
Yeah.
Now, that's what I say when we talk about these doctors who are invasive radiologists that we use to get needles to biopsy things. I said, look, that's a tiny little thing. It's got a bunch of stuff around it that's got Latin names. That's our way of saying it's real confusing in the middle of the heart or the middle of the brain. Everything up there's got a Latin name, right? So to make things simple, I just say, look, there's a lot of stuff up there that's got Latin names, and you don't want somebody with a needle sticking stuff in there unless they know exactly what they're doing. All right, I'm going to give you a couple of... I've previously said that if you're iron deficient in the United States, you are bleeding because all of our foods are fortified with iron. Now, I will tell you that the most common cause of seizures in men over the age of 50 has not changed since I was in school 60 years ago. One more time, what's that got to do with our topic today? The most common cause of a seizure in a man over the age of 50 is metastatic lung cancer to brain, not a brain tumor. You with me? Now, just change that from seizure to 50 years old and confusion, because it's the same thing. What's this here? Big old algorithm. All right, I'm going to spend just a minute on this algorithm. So at the very top it says there is a possible or probable brain tumor, something in the head. So that's where they got the CAT scan. It was done at night in a community hospital. It's not diagnostic in any way. They don't give IV contrast. It just shows there's a blob up there somewhere, and it's beyond the scope of this hospital. And this guy's not doing good. And if you read the question well, he saw an oncologist the next morning. And they went ahead then and they did an MRI of the brain. So basically, when you start working through here, it get right to, if it's where I just showed you, if it's on that lining, which is called the dura, then that, if it's there, there are a lot of benign tumors that are there that are not malignant. So if it's there, you go one direction. If it's not the other, you go the other direction. But what's the very first thing it says? Metastatic
disease. Yes.
So when you got something, I'll go a little bit farther. So when you start looking, you don't think of primary brain tumors first, because that's not the most common thing within the head. And there are certain features about multiplicity or roundness or not roundness or whatever that would drive you to the idea that this didn't start up here. This is a tumor from somewhere else, like lung, if the guy was a smoker, that has gone to the brain, but it manifests itself first in the brain. So when you get to right here, just to make it easy, this is where you start searching for something else. You do a blood count. If there's lots of lymphocytes in it, then you're worried about non-Hodgkin's lymphoma. We talked about that. If the guy's a cigarette smoker, you're worried about lung cancer. If it's a woman, you can be worried about breast cancer. You can pull that down now. But the point is, you don't immediately go biopsy it. You don't immediately think brain tumor. The oncologist got him biopsied immediately. It says right here that CAT scan showed a big mass. The next morning at an MRI, and a brain biopsy was done by a brain cancer surgeon. So what happened there was that MRI of the brain had no features of metastatic disease, which was at the top of that algorithm. Either in the ER, while they did that MRI, they CAT scanned the rest of him looking for a lung cancer or something and did not see it. So probably, I don't know whether they sent him to the MRI machine and told the brain surgeon he was going, but I guarantee you that all happened in the same morning. So once that MRI had been done, brain surgeon came down there and washed his hands and went in the operating room and bored a hole in his head, and then they biopsied that thing, and by dark they had a preliminary diagnosis. So the next, okay, show up the next one. So we know from the question that he had glioblastoma.
Glioblastoma.
Okay,
glioblastoma.
Okay, pull that down, because that is, and you'll notice that guy is holding his hands like this. So the common symptoms that get you to go to the ER sooner rather than later, this guy was not intoxicated, he didn't have kidney failure, and he was dramatically confused. Well, you know, if the guy's been drinking and stuff like that, you might, but if a guy's confused and he's basically healthy and things ain't right, this neighbor did the right thing. They went straight to the ER. They didn't take him home and sit around and wait a few days to figure out what happens. An intractable headache, seizure, double vision, things like that get you to the doctor first. Now, if you got the flu and you got a headache and you're aching all over, you stay home. But this list of, you know, cancer 7 danger signals all on the head gets you there. So that's what they did. Get the next one. Now, this is not his picture. But if you look at this tumor on that side, I mean, obviously this doesn't look like this. That would be able to be removed because it's not crossing the midline. And this part of the brain right there would not make him paralyzed. It would take away some of his memories, maybe make him some of his emotions, but you would be able to debulk that tumor surgically, and the one on this side you would not, because maybe you can't tell, but it does hit the midline. I'll pull that one back. This next thing here, and we won't stick to this terribly long, but if you look real carefully at this kind of a cartoon, and you see each of those little humps in there.
Yes.
You can pull that down. The brain surgeon would look at that brain and then have that thing in his head in the tiny little, you said, tiny little places might make you paralyzed or lose your memory or something. And even some big places you can lose and some tiny places you can't. And that's what he's going to do right there. Pull the next one out of here. So here is what was done to both McCain and to Kennedy. Not appropriate in this man because of the size of his tumor. You got the next one up there now? So you'll see this. You can take out a hunk of skull. Now this hunk of skull, if you look at it, is going to be about half again as big as the top of that can. That is going to be removed. He's going to then go in there with a knife and a little buzzer and debulk, not remove the tumor. Okay, I'll explain that just in a minute. Then close that up, pull that down. I tell people when you're thinking about a glioblastoma to imagine that you've got a handful of pancake batter that you slap against the wall. Well, most of it's going to be in the middle in the clunk that you threw, but it's going to splatter like this out a significant distance. Well, that glioblastoma has splattered out through much of the adjacent brain. But if you remove that biggest hunk and then imagine looking at the wall, then you've got pancake batter going in every direction, but in terms of the volume that you threw on the wall, that might be only 5 or 6% of the total amount that was there. Did that make sense?
Yes.
So removing that center part leaves a lot of tumor, but it's 95% of the bulk. Is that okay? You got to figure it out. Am I making sense? Okay. Sometimes I'm helping you build a watch. You can't remove that. Now, you remember what we've said before about we gave radiation therapy to the colon or to the breast, and we gave low-dose chemotherapy to increase the sensitivity of the tumor to the radiation. The analogy I use is everybody's known somebody who walked outside in the sun for 20 minutes and came in and turned bright red that was taking an antibiotic, and the doctor said, oh, the antibiotic increased your sensitivity to the sun. So put the next one up. So the treatment that this man is going to get is pills and radiation therapy. And those pills, that's radiation therapy. You've seen those a lot, right? So they've got a mask built for him. His head actually cannot move. It's in a vise that holds his head straight. That cone then brought down onto the head with the precision of a computer. You just imagine like you've got a machinist that's grinding your valves or something. It sounds, but these grinding your valves to 1,000th of an inch, right? So this thing here is precise to the 1,000th of an inch. You're taking a pill to increase the sensitivity to the radiation, and that's how the radiation is given. Okay, pull that down. Now, the survival of a glioblastoma prior to the days of chemotherapy and radiation was roughly 6 weeks to 6 months. Once they added surgery and debulking, it went from 6 weeks to about 9 months to a year. Once they added the radiation, it got to 9 months to a year and 3 months. Once they found the chemotherapeutic sensitivity pills, it got to 2 years. But still, it is a constant treatment. It is constant week in, week out, getting to the doctor, getting to the radiation therapist, getting a blood count. They'll never drive. Immediately, I tell the family, get durable medical power of attorney. Don't let them borrow money. Don't let them go somewhere with a credit card. Don't let them write checks. You know, how these scam things do. They got to be protected. And the outcome is going to be the same thing that happened to McCain and to Kennedy, and that is within 2 years they're not going to be survived. Now I've got a patient that's 10 years, another that's 20, but those are so rare that you don't try to print. You can tell them that, but basically it doesn't make any difference how much money you got. You're not going to do well. So his questions to me are, what am I supposed to do as his neighbor? Well, basically, the first thing I would do is immediately, if he had this brain biopsy, he's in a cancer center with a neurosurgeon. I would go immediately to their social service department and let that social service worker start investigating family ties. Does he have any? Is he a veteran? Can he get to a VA hospital? And what other support exists other than the guy that's asking the question, who apparently is doing everything for him? Because somebody needs to be available to him continuously for 2 years until he succumbs. What sometimes happens is this guy is still capable of making decisions. He's not, you're not going to want him to drive, and you're not going to want him to spend a bunch of time, a bunch of money on something. But he can say, yes, I'm willing to get treated or not get treated. So once you've discovered, does he have cousins? Does he have any family at all? Because there's nothing here about any family being available. He may elect to take no treatment. Many men in their being told that you're not going to drive again, you can't be in control of your money, will elect to say, if the outcome's going to be bad in a year or 2 years, then don't treat me at all. Does that make sense?
Yeah, I mean, we've had those kind of questions before on quality of life, and what you put yourself through and those kind of decisions. I mean, you may sit down and it sounds like in the 2 years that you have, and the only way to talk about it, it's
all psychosocial. It's you and family. It's
yeah,
you.
but what I'm saying is these treatments are ongoing, and it's not like you're going to have the best quality of life in those 2 years.
All right, you remember that
also.
question we had about wearing the plates, the electric plates on the head? This patient, if he is treated, is going to wear those electric plates.
Well, that's why it's real. I'm trying to be real sensitive with it, but this is a decision of like, okay, 2 years, and I'm going to be going every week, and I'm going to be doing this.
I might be wearing that plate.
Right.
I mean, okay, well, now let's get back to this. So I'm going to tell you, we're sort of through with this guy. But I have a patient that was 60 or so. It was a very, very big industrialist that has recently succumbed to this disease and dramatically wanted to be treated. And there were reasons. One, he had a very supportive family, big family. He had plenty of money. He was able to get people into the home to help his wife with everything that needed to be done. But he had 2 grandchildren that were in college that he wanted to try and see graduated. One was graduating in a year, and one was graduating in 2 years, and he saw both of them graduate. Now, the second one, he might not have remembered it too well. But it brought that family together dramatically. It was wonderful for that family to have this really good year with their father, grandfather. And it was not a big burden on the family because they were able to have support and full-time help in the home. Now, you got the other situations where there is no family, or the family is estranged, and that family is not going to be there, and the guy may say, I don't want treatment. Both of the diseases are the same. Both of the ages are the same, and the outcomes will be the same. But the way those families exist together and how they want to live their lives is entirely different. So every time I see a patient, I say, I am not treating a chart. I'm treating a human being. And here is how this can be treated. And here is the problems you'll have with it, or the good things that you'll have with it. But you're going to decide, for example, whether you want to have a mastectomy. Most people don't need it. But if you want a mastectomy, we'll get you one. So this is where oncology gets out of being algorithms and best information, and gets into the human being treating patients and treating families the way they want to be treated.
Let me suggest to check all your churches in the area. There are several churches. Now, I don't particularly know, but I know of this around the country in different areas. There's several churches where the people, their ministry is just to take people to doctor's appointments.
Yep.
And it's not uncommon to find a team within a church that gets together, and what they do is they help by taking people to doctor's appointments. So
that are not members of that church.
Just
in the community somewhere.
Right, in the community, right. That help people,
Right.
And some people, that's their ministry. So let me say this, Diana, are we having a sun issue? Jeremy, can we move the truck up just about a foot or two? Thank you very much. We have our shade here, and I noticed Diane adjusting the camera. Must be a sun issue, so we'll get the truck moved up a little bit to block
Another
this.
beautiful day in Blue Ridge.
Oh, it's beautiful. Georgia Cancer Specialist affiliated with Northside Hospital Cancer Institute. We appreciate it. Now,